Hello everyone, my name is Ariella Bach and I live in Gainesville, Florida. I currently work for Gainesville Fire Rescue. My role within the fire department is somewhat different from being just a typical EMT or firefighter, as I am the program manager for a community paramedicine program. This program works in line with the International Health Institute's triple aim, which seeks to treat patients in appropriate settings. Most of the work that I do with patients is done in their home on a one-to-one basis, as myself and a paramedic enter their homes and complete a full patient assessment both on their medical picture and their social picture, with the goal of connecting their social needs or social determinants of health to existing resources in the community. And a number one need that I have seen across the board is improving health literacy. I'm so excited to talk to you all about that today.
Hi everyone, my name is Lorena Pantoja. I'm an anesthesia practice manager with ZeroMed Physician Services, and today I will be covering effective strategies that we as healthcare professionals can employ to effectively convey information to patients who suffer from hearing loss or are completely deaf, to patients who are visually impaired, as well as patients who suffer from delirium, dementia, or are advanced age patients.
Hello everyone, my name is Christopher Shu and I live in Delray Beach, Florida. I currently work as a board-certified ED physician at Treasure Coast Urgent Care and Martin Memorial Hospital. As a provider, my primary role is to diagnose and treat my patients, as well as properly educate them through preventative care and a full health assessment.
Hi everyone, my name is Morgan Picard. I currently live in Fort Lauderdale, Florida, and I work at a private practice where I diagnose and treat varicose veins as an ultrasonographer. The purpose of our presentation is to really inform everyone how important communication is for patients to understand fully and just be more educated. Once this is attained, patients' health behaviors, patients' health status, and their compliance will greatly be improved.
Thank you, Morgan, for starting us off. Only 12% of our current adult population has the capacity to understand health information. Health information includes anything from reading medication labels to understanding discharge summaries from the hospital. And this low rate of health literacy has larger implications, including driving up cost of healthcare and ultimately a more ill population. This is an example. Here you see our current emergency system. A 911 call or emergency room visit is generated by the onset of an acute medical symptom. Inpatient in the emergency room, that medical symptom is then treated via medication or any extra intervention. Upon discharge, that social issue which generated the call in the first place remains and is not treated by the hospital. This can be anything from not knowing how to refill a medication, or maybe not having transportation to see a primary care physician. Ultimately, this cycle continues with that social issue remaining at the core of the problem and becomes the catalyst for further issues. This is the reality of our health system. A way to combat this issue lies within health literacy and education. Communication with patients is key in understanding what problems they may face and mitigating any issues in the future. Today, I'm going to do an overview of Chapter 6, Adapting Communication to a Patient's Ability to Understand. To review, in the United States, only 12% of adults have identified as proficient within health literacy. Low health literacy, language, and physical impairments all inflict confusion and thus affect compliance with the healthcare plan. This leads to, as we discussed before, increased readmission rates and utilization of emergency healthcare services. Populations that experience low health literacy include older adults, racial and ethnic minorities, people who did not complete high school, low-income individuals, non-native English speakers, and those suffering with a chronic disease. And this can be for a number of reasons, from not understanding disease-specific terms to just not understanding language on a higher level. Health literacy can be defined as the degree to which individuals have the capacity to obtain, process, and understand the most basic of health information and services needed in order to make appropriate health decisions. It should be noted that this also includes knowing how to navigate the healthcare system as a whole, as well as numeracy skills, so understanding the correct values associated with a specific disease process. According to the CDC, patients with low health literacy are more likely to visit an emergency room, like we discussed before. They're also likely to have an increase of hospital stays. Upon discharge, patients with low health literacy are less likely to follow up with treatment plans constructed by their physician, and thus they're likely to have higher mortality rates. This leads me to my next point. Why is this so important to us as healthcare providers? Individuals with low health literacy are likely to lack insurance, have chronic disease, be hospitalized for their chronic diseases, and have poorer health outcomes. Ultimately, if one can't understand the process or the wording of how to sign up for insurance or how to research their chronic disease, they're not going to be able to connect the dots to how their daily living affects that disease process. And they're certainly not going to be able to understand how to get help for it. 9 out of 10 people lack the skills that they need to manage their health and prevent chronic disease. People with limited health literacy lack the knowledge of the human body and the etiology of their disease process. These individuals may not understand the impact of certain lifestyle factors on their health outcomes. This leads us to facilitating this cycle of our health system where one doesn't understand how they can better their disease process or self-manage, let alone get help for it. Ultimately, the responsibility falls back on that healthcare provider to engage with the patient and make him or her self-sufficient in disease management. We cannot just rely on one type of physician. The physician in the emergency room, along with that primary care physician, needs to all be on that same page and work with the patient on wanting to engage with their management of their own health. Now I'm going to review some strategies that you can employ as a provider to help overcome low health literacy. Firstly, we need to evaluate the patient's current understanding of their disease process and their literacy as a whole. We do that by using the teach-back method. I often employ this method upon first meeting my patients and by asking them questions, simple questions, including, what do you know about diabetes? Or what does high blood pressure mean to you? Do you know the adequate range that your blood pressure should be within? And I wait to hear their answer. Keeping it open-ended really allows the patient to tell you what they understand so you can better gauge how to help them. Next, limit the number of messages given at once. We do not want to overwhelm our patients. Use plain text, so no medical jargon. Know your audience. Are you speaking to a retired professor, or are you speaking to someone who did not finish the 3rd grade? Use visuals to support your message. Adapt medication routines to fit the daily life of a patient. A patient is going to be much more receptive to listening to your instructions if what you're telling them to do is easy to implement. So ask them questions about what they would need in order to do what you're asking them to do. Prepare all of your forms at a 5th or 6th grade reading level. Be mindful of format, so we don't want to overwhelm them with size 10 font, filling out a full form back to front. Also, I recommend that you should review documentation verbally with your patient. Now I will call upon Lorena to pick up and tell you more about some more strategies that you can employ to overcome low health literacy, specifically with individuals with specific impairments. Thank you all.
So why is it important for us as healthcare professionals to adapt our communication to a patient's ability to understand? One important reason is there are 76 million baby boomers in the United States. Of that 76 million, there are 25 who are visually impaired and 28 million who are deaf or hard of hearing. In addition to that, 10% of those 76 million baby boomers over the age of 65 will suffer from dementia or delirium, and that number goes up to 50% once they reach the age of 85. So being able to effectively communicate with our patients is going to increase compliance and essentially improve the patient outcomes. First, I'd like to begin with strategies we can employ as healthcare professionals when having a conversation with visually impaired patients. Suggestions include greeting the patient, speaking directly to the patient, same as you would with any other patient. Identifying yourself. Tell the patient when you're going to touch them with a cold stethoscope or any other medical device. You want to provide reasonable accommodations, and what I mean by that is if you need to provide the patient with literature, make sure it's in Braille, or make sure it uses fonts that are bold and has some sort of contrast with the background. And lastly, you always want to tell the patient when you're leaving the room. Very important. When talking to patients, having a conversation with patients who are deaf or suffer from hearing loss, there are also strategies you can employ. A lot of times misdiagnosis can happen, or medication errors due to ineffective communication. So you always want to be sure the patient sees you. You want to interact directly with the patient. You want to provide reasonable accommodation. And what I mean by reasonable accommodation is sometimes the use of a professional interpreter is needed. And when you use a professional interpreter, you want to make sure you don't use a lot of medical terminology. The reason I say that is because American Sign Language differs very much from English. So you want to use very words that are easy for the interpreter to be able to convey to the patient. You want to maintain eye contact, and you also want to supplement with visual aids. Patients with advanced age, delirium, and dementia. So for patients with advanced age, you always want to speak slowly and clearly. You want to repeat information and write down instructions. You want to focus on one topic at a time and always maintain eye contact with your patient. You want to use visual aids as well. Now, when dealing with patients with delirium and dementia, your approach is going to be a little different. You have to be a little more patient. You want to approach the person from the front, always call them by their name. You want to respect their personal space and avoid any sudden movements. You want to ask one question at a time and avoid and give step-by-step instructions. And lastly, you never want to disagree with them. You want to try to be sensitive to their needs, supportive, and always remain soothing. With that, I'd like to introduce you to my colleague, Dr. Christopher Hsu, who will be discussing patient education. Thank you.
So I'd like to start off with this little graphic here, which represents a typical issue in healthcare or a normal circumstance with communication. Most often than not, we listen to reply, not listen to understand. We have Bill and Ted here. They're trying to communicate, but there's obviously a brick wall or a barrier interfering in their communication. Bill is speaking, but Ted is not hearing. Ted is hearing something, but not the same thing that Bill is speaking. This poses a potential problem because misinterpretation can lead to further issues down the line. This relates because in healthcare, we need proper communication through all levels, including all providers, all the way down to mid-level practitioners and patients. So what happens when this fails? Does the patient not receive proper treatment, or does he fall, or do we drop the ball, or the patient literally? We all play a vital piece in patient care, everyone, we're all pieces to the puzzle. We need to come together and create an environment where a patient wants to understand, but we need to first assess how we need to educate them and create the environment where they feel comfortable in learning our teaching methods. So let's go over some benefits of patient education. We get a reduction in medical costs through a healthier lifestyle, increased compliance, and decreased complication. We often have patient satisfaction increase with patient education, and it parallels each other most often than not. They also have an increase in self-care and confidence because they know directly why what we are saying and how it works in their life. Increased patient safety because they're more knowledgeable and they have less injuries from potentially not knowing how to use a medication or stopping it inadvertently. Patient education plays a pivotal role with changes in health behavior, status, and patient compliance. When we assess a patient and design instructions, we provide a stepping stone for increased knowledge. As healthcare professionals, we are directly responsible for diagnosing, treating, and preventing disease progression. Our primary focus should be centered around creating an environment where a patient feels comfortable learning about their disease and its management. So when we assess a patient, what are we doing essentially? We're looking for any context of how we can educate them. We're also evaluating their demographics, their learning styles, which is a huge part of how they understand, and the info and content that is included in each teaching style. So when we are making that assessment of our patient for the first time and how we can educate them, there are several contexts for education: situational and instructional. A situational context is any kind of medical condition that creates a need for instruction, any kind of chronic disease, surgery, acute illness, any situation in that sort of nature. An instructional context is where we will design the instruction, such as your office, a hospital, or a clinic. So when we're thinking about these contexts, they should be tailored to a patient's educational and social economic background. So what is one of the most important factors in determining a patient's response to instruction? That being patient demographics. It involves a subgroup of ethnicity and cultural background, socioeconomic state, their native language, age, education level, healthcare background, and literacy and knowledge, as well as physical and psychological conditions that may affect their ability to understand and interpret information properly. During medical school and in my training, my mentors often told me that the difference between being a provider and a great provider is one who treats the patient who has the disease and not just the disease itself. Now we know the information through our initial assessment of what we want to tell our patients. We need to determine what their preferred learning style is. Every patient has a known preferred method of learning content. Each teaching method should be geared towards how the patient will respond and understand information the most efficiently. So we have many different types of learning styles, one being visual, which is the use of models, pictures, diagrams, literature. Most people learn in this way, including myself. Auditory learners, verbal questioning and answers, little less profound group, but still significant. You have kinesthetic learners, which the provider demonstrates how to perform a task or taking medication, which is the minority of the population, but there are still importance to these. So with all three of these learning methods, we have to properly use content analysis, which is us as providers, we need to sift out what's absolutely necessary to tell them and what's not important or pertinent to why they're there or being treated for. So content analysis, we essentially sift through information and give them the most essential parts of why we are educating them, such as triggers to avoid, treatment options, and proper use of medication. Non-essential information includes prevalence in the population or potentially side effects of a drug. So now that we've gathered and structured information based upon our initial assessment on the contexts and how a patient learns, we need to know how to design instruction for them. First, we need to establish behavioral objectives. So essentially, that you're telling a patient why specifically their treatment regimen is going to help them and how it's going to be beneficial in the future so they can understand the current state and the actions you're taking to help their disease management. For example, an obese patient and why a diet and exercise program will result in weight loss, or a hypertensive patient and why 100% compliance with their medication is ultimately needed to keep their blood pressure within normal limits. We also need to organize content so instruction is received clearly and comprehended understandably by each patient. We also need to restate and repeat instructions as necessary in order for validation from the patient that they can understand what we are communicating with them. I tend to look at this, and we should look at this as an assembly line, because each piece of instruction is equally as important as the latter and former. Without each and the other, we can't move forward, and eventually, if one piece is missing, then the whole scheme of things will come to an end. So one of the last steps in educating a patient after our assessment, we need to select a strategy and resource. During your instructional sections, we should use models, videos, and visuals for all the visual learners so they can drive home the point as well as understand what we have just said and summarize everything. Also, we should give them some kind of reference at home, whether it be written, an audio, or follow-up, because that'll often re-jog their memory and sometimes help at solidifying what they may have questions on. Now I'm going to transition to the selection of teaching strategies and resources, which Morgan will go over.
Thank you, Chris. So you know the saying that every snowflake has its own unique identity? Well, the same goes for patients. Not everyone learns in the same way, so I'll be touching on personalized patient care through strategies and resources. First impressions are key in any setting, so make sure to welcome the patient to establish a caring relationship with confidentiality. The Ask Tell Ask works by asking the patient what they know, telling the patient about their diagnosis, and then asking the patients what questions they have. In order to have a professional speaking voice, you want to be calm, reassuring, and authoritative. We tend to forget patients don't have the health knowledge healthcare professionals do. For patients to better understand, stay away from medical terminology. Using the second person means you instead of third person people or patients. Like the little illustration shows, keep things simple, stick to the ABCs and building blocks. Forming the message for individualized patients will help design instruction for change. Being specific influences a patient's comfort with instruction and expectations. Use your white coat. This will help make unpopular recommendations to patients and emphasize benefits. Repeating enforces the message and encourages patients to make a commitment. And asking the patient questions will help better understand their point of view. Lastly, patient behaviors and learning habits. Small changes will avoid patients feeling overwhelmed or unattainable. For example, if a patient needs to lose weight, instead of asking them to work out 5 times a day, maybe ask them to walk 15 minutes 5 times a week. Work their way gradually to accomplish this goal. When linking new behaviors to old behaviors, if a patient needs to take medication twice a day, ask them to take it and incorporate it with their teeth brushing schedule. This is hopefully every morning and every night, so this serves as a reminder to them. From personal experience, I believe combining verbal communication and visual aids help incredibly with patient education. Most of my patients are nervous before their first endovenous laser procedure, expecting it to be extremely invasive. I reassure them it's minimally invasive by showing them the size of the catheter and the laser fiber. And this definitely helps calm them and reassure them everything's going to be okay, and they feel more comfortable in the end. Patient education and proper communication are critical to ensure patient compliance and comprehension. With that being said, the next section includes a short video that identifies important tips to better understand and communicate with someone who has Alzheimer's or dementia. A little summary of this video. People with dementia or Alzheimer's have difficulty expressing thoughts and emotions. Create a kind voice that is slow and clear, and always introduce yourself no matter who you are. Questions should be short, simple, and one at a time. Be careful not to interrupt, criticize, or argue, and let them know you are listening.
So to sum everything up, how do we bridge the gap between patient education and communication barriers? We have to use specific communication methods tailored to each patient. This creates an urgency and desire to play a part in management with their proper understanding and playing their part. We need to actively work on enhancing our communication skills every time, and this allows us to create optimal disease management. So in order to progress in disease management, we must learn to modify and tailor our communications and proper educational ways to make medicine understandable and relatable for every patient that we encounter. In that way, we all win.